Thank you, Louie, and thank you, everybody. Good morning. This reminds me of a hurricane drill, having the having the translator here. Thank you. All right. I'm delighted to be here today. This is such an exciting and busy week for us in Washington and across the country during National Health IT Week, and I so appreciate the partnership of the National HIT Collaborative for the Underserved as we're working together to reduce health disparities. As the National Coordinator for Health IT, our office is tasked with putting health IT in the hands of the nation. That means everyone in the nation, and creating an interoperable health IT system that makes information available when and where people need it. I have now been in this role for 246 days. Not that I'm counting, but every day counts, and we don't have much time to meet the needs and expectations of our community. And I want to assure you that I wake up every day thinking about how I can best serve everyone in this country, everyone, with a focus on those who need it most, and particularly those who often don't have a voice. Inequities related to race, gender, ethnicity, and socioeconomic status are one of our nation's most vexing problems, affecting health status, access to care, and health care quality. Racial and ethnic minorities continue to experience significant disparities on many outcome measures. Health disparities populations are less likely to receive the preventive care necessary to stay healthy, more likely to suffer from serious chronic illness like diabetes, heart disease, and when they do get sick and seek care in the healthcare system, unfortunately we know that they also often receive worse quality care than their peers. Health information technology such as electronic health records, mobile technologies, telehealth, disease registries, are known as a way to deliver safe, more effective care, more affordable health care services, and coordinate care across the continuum for everyone. It's a way to provide a critical population that we all care about the data necessary to catalyze and improve their health, to make sure that policies are informed by data and that we're keeping an eye on opportunities to improve. At ONC, we're determined that we will use health IT, not just electronic health records, but the broad spectrum of health IT to improve the health of everyone in this country. Adoption and meaningful use, lowercase, of health IT is even more critical within the context of underserved communities. Within both rural and urban settings, access to primary and specialty healthcare resources can be limited. The scarcity in many instances contributes to the reduced quality of care and health outcomes for people living in these areas. With underserved communities, the use of health IT has demonstrated it can improve health outcomes from the individual and community and system-wide level. It's a powerful tool to achieve quality of care because it can meet people where they are and help bring services to them that might otherwise not be available. Health IT makes care not just flexible, but also potentially customizable in a way that we're only beginning to understand and imagine. It helps folks who are, for example, more likely to be visual learners or hearing impaired, whose first language may not be English, who might need a larger font size. I think my staff put that in there for me. Couldn't resist. It's malleable potentially in a way that can meet the needs of really the diverse populations of this country and the people that we want to serve. It's a powerful tool that we can begin to use to address disparities in care. In March of 2013, we published a report, which I encourage you to seek out on our website, healthit.gov, entitled Understanding the Impact of Health IT in Underserved Communities and Those with Health Disparities, to help us better appreciate the impact of health IT on these communities and see what ways we could begin to use health IT to address and eventually eliminate health disparities. It looks at how communities and providers are using health IT to address the specific needs of populations experiencing disparities in access, quality, and affordability. The key findings are the following. Health IT does have the potential to affect the health of populations experiencing health disparities. It can enable effective redesign of healthcare systems that can advance elements of the three-part aim, that is to improve quality and do that at a lower, more affordable price, and improve the health of everyone. Programs are encouraging the uptake of health IT in underserved communities, particularly in rural communities and in the federally qualified health center populations. And national efforts to encourage health IT adoption to improve the quality of service delivery by safety net providers like FQHCs, like critical access hospitals, like rural hospitals, were taking place before high-tech was implemented, but high-tech provided the funding necessary and the resource support through the regional extension centers to see that technical assistance was available on the front lines to providers when they needed it most, so they weren't just expected to purchase and adopt an electronic health record, but be able to adapt practice to meet the needs of the patients they serve. We are leading these efforts and working with our partners to accelerate adoption and optimization of not just IT, but also the opportunity to really change care and see that data follows patients in a connected way. A critical piece of our strategy is the regional extension centers, which I mentioned. They're charged with supporting primary care providers, hospitals on the front lines. And if you don't know, you should know that my predecessors took great pains to see that we focused on using this important national resource, the regional extension centers, to reach out to communities and providers who were potentially least likely to have the assistance. We had targeted efforts with rural and critical access hospitals and the safety net system. And I will tell you that it was very largely successful in reducing the potential digital divide for those communities. Underserved groups served by those communities do face unique challenges. We also found in this report that there are examples of issues that providers must address to meet the needs of these patients, particularly in challenges around health literacy and English proficiency, or populations with English as a second language. Some communities have demonstrated remarkable advancement using health IT to be able to assist those populations and improve the care and accessibility of the services provided. There's some case studies in the report that demonstrate that safety net providers do struggle sometimes to address the configuration and customization of health IT applications to address not only their needs, but the needs of the populations that they serve. Resources and programs that only address general barriers to health, to IT, and to health care may miss really important subtle barriers. It is incumbent upon all of us to see that we are working collaboratively, but more importantly, listening to the people we serve to understand how this powerful tool of health IT can advance care, but more importantly, advance their health. So what is next in our efforts to reduce disparities? We'll start with leveraging. We believe that health IT is a tool that providers can use to identify, to address, and ultimately to decrease disparities. Reducing disparities is a key part of our commitment to improving overall health outcomes and reducing the gap in this country. We're working to identify innovative ways to use health IT to achieve reductions in disparities. So for example, through our Fellows program, our Health IT Fellows program, we work with frontline providers who are thinking of how they customize their systems to meet the needs of the populations they serve, and how we create a learning community to share that information across the country. The next is partnership. We believe strongly that we will not do this alone at ONC, and I hear from your remarks this morning, Louis, that we're going to do this as a public-private partnership, and we strongly believe in that. We want to engage a broad set of stakeholders, broader than we have had an opportunity to engage before, in our FACAs, that's our advisory committees, in our work groups, in our fellow programs, in our conversations, to see that we are reaching people in all corners of this country, and that there is an opportunity for both voice and vote, so that we can make certain that we're meeting the needs of everybody in this nation. The next area is around adoption and tracking. We remain committed to seeing that where disparities initiatives are needed, we are helping providers, regardless of the populations they serve, to have effective IT systems. We currently do this through our regional extension center programs, which work with frontline providers, but we are working to adopt and adapt ourselves as we move forward from that regional extension center program to look to the future to find ways that we will not leave anyone behind in this country, including providers and the populations we care about, and make certain that they have the tools and capacity that they need to continue to move forward to adopt health IT, so we can be able to measure how we are doing as a country on a broad scale. The next area is around care quality and quality measurement. Quality measurement is critical. You cannot improve what you cannot measure. ONC has been hard at work examining how health IT can help populations with disparities better manage care, increase access to care, and identify disparities even within subpopulations. As we work with our other federal partners on the future certification policies, we'll continue to examine how quality measurement, not just measures, and health IT functionality more generally can aid in disparities reductions. Several stakeholders at the federal level and the private sector and members of Congress have expressed great interest in understanding how we can stratify populations so we can better identify disparities. And we are working with them to think through how the technology collects that information in ways that are sensitive and appropriate, but also can help shape this country's knowledge about ways that we might need to help those that we care most about. For ONC, when we speak of a vision of meaningful use beyond electronic health records, that is, health IT beyond EHRs, and health beyond health care, that is, to be able to address the social determinants where people live, learn, work, and play, and the opportunity to think about using levers beyond programs like meaningful use, but what we all have in our toolboxes at the federal level and in the private sector. We are working together so that we can tackle the challenges for all of our citizens, all of the residents of this country, regardless of race, gender, ethnicity, socioeconomic status. We want to applaud the efforts of the Collaborative for the Underserved and congratulate you on your first meeting, and we hope that there are many more to continue to shine a light on this important issue, to bring attention to the fact that if we're going to move ahead as a nation, this must happen collaboratively. The tent must be big, and we are committed to widening that tent so that we have as many voices and perspectives as possible at ONC and with our federal partners and others and beyond. So we look forward to working with you all, and we wish you all the best and continued success. Thank you. I'm going to do questions. You do questions?
Yes.
Can you stand or sit?
No, you can
Stand?
stand.
Right.
Dr. DeSalvo is going to take some questions. So if you have any questions, go right ahead.
This is your chance. Well, thank you for the question and all of your great work in Puerto Rico. The policy goal is that everyone comes along, everyone, and that word has a lot of meaning for me. You'll sometimes notice that I use it, but I don't use it lightly. And that brings with it a host of challenges because this country is incredibly diverse. And if we only paid attention to the high-performing systems, like the one we're standing in, that have the resources and capability to adopt and to adapt, we would be missing the really important need and opportunity as a country to bring everyone along. But that doesn't mean it's easy. And you know, the amount of resources that we had in the Regional Extension Center program were designed to carry the water for stage one, which meaningful use, which has been incredibly successful with respect to implementing that structural implementation of electronic health records on the front lines. They beat their goals of the number of providers to be reached. 150,000 and 100,000 primary care providers have attested to meaningful use. When you look at the data for how we reached and supported and helped with the adoption of electronic health records, what you see is that, as you mentioned, safety net providers did extraordinarily well. Federally qualified health centers, safety net hospitals, critical rural access hospitals, in addition to larger systems. The gap is in the small practices, and it's those small doctor shops And many of them are minority clinicians serving predominantly minority communities who have shared with us that they don't feel that they were part of high tech, that it wasn't for them. And I have heard that, and it is essential that we as a country sort out a way to overcome that, because this is for everyone. Now, the reality is the Regional Extension Center program, as you say, is sunsetting. And so I think for us at ONC, understanding how the set of relationships we have, the data that we have in our management tool is a window into the country, helps us see gaps where there are clearly gaps, not just in the health outcomes for populations, but in lack of visibility of data, because there's a lack of adoption and participation, and work with everyone to sort out the best path forward to continuing those regional extension center supports. HHS does understand, now here I'm speaking broadly for HHS, that providers need support on the front lines. They need tools to help them change. They are not going to just be able to adapt to new models, especially if they're in small practices. For those of you who don't know much about me, I don't just say that as a policy person. I actually had the joy of starting some health centers in New Orleans from scratch, which are now federally qualified health centers after a lot of years of struggle, financial and otherwise. We had purchased and adopted electronic health records in that environment. I know about how you're trying to pull nickels together to make that work. I understand how that stops everybody in their tracks, which really messes up your billing, because you are trying to teach everybody a new workflow and see patients, and we did that twice. So I actually also have some understanding, and we weren't doing that as part of a big system. That was us, you know, a handful of us rolling up our sleeves to get that work done. So I have a real appreciation for what that feels like, and I also understand how much work we have to do with the technologies available on the front line to see that it meets, for example, the language proficiency that we would all expect. And I also understand, while I'm on a roll, that that this training piece, this frontline piece, isn't just about teaching the doctors or the systems which EHR to purchase or how to develop a contract that will allow them to participate in the interoperability space. But there are a host of incumbent workers on the front line who need additional training to make sure they can stay in the workforce and advance in the workforce and be a part of this revolution that's happening in the country. We had some work in that space at ONC. We continue to work with labor on ways to carry that forward through curricula, but also through additional advancement programs. And it's something else I know it's important. I just want to make sure I nod to it. It's not just about the docs. It's about the people who are actually doing a lot of the work in the front office and in the back.
Dominic Mack, Morehouse School of Medicine.
How are you?
How you doing?
I'm great, thanks.
Thank you for being here today. My question is easy. As the funding, as you stated, sunsets around the High Tech Act that ONC has been managing, how do you refocus, and what is your vision for the future over the next 5 years?
So the high-tech funds, as stimulus Act monies, were designed to catalyze and stimulate in the marketplace. And we are close to putting out a report that it will be out in the next few weeks to share what we have accomplished and what we're learning as a country. Part of that, obviously, when you're engaged in a report with external evaluators, you're doing a lot of reflection. In the last few months, we have been reflecting at ONC. And in fact, when I came in to office 246 days ago, I took a breath and asked everyone else to do the same and look up and look around and see what we were missing. And you know, we had gotten appropriately very focused on the high-tech funds and thinking through the responsible spending of that $1.7 billion plus the $24 billion more now in meaningful use. But to this point about that everyone comes along and the opportunity, I think, you know, it should be clear to you all that if we only thought about meaningful use or those grantees, we would be missing a lot of the country. And it is, I believe strongly, it's our responsibility to think of the entire care continuum. So non-MU providers. Behavioral health is a personal passion of mine, but so is long-term post-acute care. And the need for that content to be digitized, the equity issue, which I mentioned, and that not everybody felt a part of this movement in a way that I think we have an opportunity to continue to press forward. So we are looking at, in our 10-year history of serving this country, the tools that were available prior to high tech in the 5-year span, and what our new authorities and responsibilities are as laid out in high tech, and merging those together with the new relationships that we have and this new foundation our nation has. Our top priority is to see that we connect care, that the data is moving with the person so it's there when they need it most. That's interoperability, which is really a means to an end. It's not, we don't just get up and want to do interoperability because that's fun. It's because we want to reduce the potential that someone has to get stuck twice or miss work to go get the same test again because someone didn't have their results. And that's foundational for really building a stronger infrastructure that can take in non-EHR, non-healthcare data to get a fuller picture of somebody's health. That really starts to bring in other data, other trading partners from the health ecosystem. To get there, thinking through the fact that the federal government is the largest payer of care. So we have an array of CMS programs for Medicare and Medicaid that are increasingly being leveraged, or we're thinking through how to leverage to drive the adoption and use of health IT and interoperability. So we work with CMS on that. HRSA has already been a terrific partner, and we will continue that relationship. SAMHSA, increasingly a great partner as they're thinking through their grantees and how they might support and enable. Those are our HHS family, and there's more. But we have set a table for a Health IT Council that's federal that includes not only HHS, but the VA and the DoD as major providers of care, but also purchasers of care, the Social Security Administration, the FCC, the FTC, NASA. I always like to say that. NASA has an electronic health record, which you probably could figure out. They have a VISTA system. So we have a broad array of your departments and agencies that you're funding in the federal government who need to work in a more coordinated fashion to send the right signals to the marketplace. And as we're purchasing and supporting and providing care, we can actually help advance technology and adoption in those ways. There are a few other ways that we're addressing it, but I'm going to emphasize what I said again, and which is that and I'm going to say it this way, to be sustainable, to stick, this has to be done by all of us. If we push out grant programs, and when that goes away, it doesn't stick. And that y'all have to carry this, because I have 2 years, 4 months, and some days left, and someone else is going to be standing here talking to you, because the next president's going to ask somebody else to stand here. And that means that whatever we form has to be something that we form together. Do I have time just to add to this? So think about states. State government has an array of really powerful levers, not just the Medicaid program, but licensure of facilities, certificate of need, participation in Medicaid programs, state grants, the re-granting of SAMHSA dollars for behavioral health. Some states are using their SIM grant money to help push adoption outside of the meaningful use providers, so Minnesota as an example. There are great examples in this country where states, both red and blue and purple, have thought through how they can use their levers. That matters so much because the instruments we have at the federal level can be a little blunt. And it's great if you want to do things like meaningful use and broad sort of push. But when you want to meet a community where they are, it's pretty hard to do from inside the Beltway. You really, even at the state level, I know it's hard to do, but it's closer. And that helps them sort of filter down and get closer to the ground. And as an insurance marketplace, it gives them more opportunity to think about leveraging change. So we've been convening the states to learn from them and hear from them how they might want to work together to do some peer learning and advance a policy academy together. Yes.
Hi, I'm Lucia. Wait to the mic. Everybody knows I don't like this, but I'm Marcia Thomas Brown, and I'm the past
Chief Operating Officer for NHIT. And currently, I'm on the operations side working in New York City with a fairly large, federally qualified health center, Morris Heights. And so, first of all, I want to thank you for being here. That in itself says a lot. I also want to thank you because in your 246 days, you've put a lot of thought, and one of your focus has been what has been painting organizations like NHIT, and that is how do we really have the government and the private sector see the benefit of partnership. And so my question is, as we put the team together that is going to carry this through, what's the role of specifically community-based organizations as being part of the team in meeting our goals as relates to ONC and health information technology for the underserved?
Thank you for the nice comments and the question. And I will share with you first the usual set of issues. So in general, there are organizations that are active in the space of health IT and regularly send us love letters, which is what I call them, and comment when asked. And it actually really matters, right? It really matters to put in writing what organizationally folks think, and it's quite helpful. That is one pathway. The pathway I mentioned of our advisory committees is is the structured way we are allowed to build consensus and to get consensus. And that is a mechanism that really informs what we hear from the ground, and I have been pushing our team, and we will continue to push the team to have a diversity of voices and perspectives on our work groups. So those are a couple of structured ways. We have to build some talent in those work groups and on the actual committees, because there's historical information, and so sometimes people don't want to be on a work group, they want to be on the big committee. But you also, I think we have to let people in every door where we possibly can. And Dr. Grassi and I have talked about this, so she's trying to help me make sure that I have better visibility of where we can pull talent. This is a side note, but I'm not an HIT person. I'm a public health, community health person. So I don't have a lot of relationships broadly, but I'm working on that. So help me keep working on that, put forward names and ideas and people. The third thing is really more to your question, which is how do you collectively have impact? And public health people in here, collective impact people? All right, so collective impact is really popular in public health right now for good reason. It is essentially a strategy where communities work together to make change, to create a social movement. And you set a shared vision, a shared set of goals and metrics so you'll know when you got there, and you find a way to collect data and share it with everyone. And within all of that, there are a set of tasks that we want to accomplish that we decide on together, and some people lead and some people follow. And I say people, it can be people or organizations. And so collectively, everyone knows who's doing what when and how we're going to get there, and there's usually a backbone organization that is helping to coordinate and manage. That's the fundamentals of collective impact. It's messy. It's why I love it. It requires there to be a lot of leadership and a lot of communication and a lot of ideas at the table. It is the way we did business in New Orleans when I was health commissioner, and it is the way that we're working to structure the change, particularly the interoperability roadmap, which we'll see how that all comes out of the wash, but in January we're hoping we'll have a roadmap that starts to spell that out and say this is what needs to get done, who wants what, and how we're going to work together. I have started some listening sessions across the country when I travel to give talks. We have sat down now, I've had a dozen listening sessions where we invite people from as many varieties of walks of life and perspectives to come. I was in Vermont last week, and we had the ACLU there, which was really interesting for the first time, with the hospital association and the vendors and the pharmacist. The pharmacist was the most disruptive in the room, talking about taking over healthcare. Really great, conversation about what's on the top of their mind and what could we be doing as the federal government to be helpful or to get out of the way. And what are the challenges? And these dozen conversations, you start to see that there's some overlap, but there's definitely a continuum. People are in different places. Minnesota is not where Alabama is. Alabama's worried, Montgomery's worried about broadband access. That's a challenge, and adoption, frankly. Minnesota's thinking about social determinants and learning health systems. But Minnesota's been working at it longer, and they're using their state levers. So that's a part of it, and we will go forward. We're planning some increasingly formalized versions of that so that the qualitative information that comes in isn't just my notebook, but is actually something structured that we can show you what we've been hearing. That informs what we're thinking about as we move to the final thing, which is in the spring, coming up with what I'm expecting to be a national agenda around health IT for the country. So some of this is us starting to listen as openly as we can on the ground, working to do that in a more structured way in the next few months, which we'll have some more to share about in the communities where we will go across the nation. And then assembling that and matching it up with what our federal strategies are and seeing if there's enough overlap or where there are blind spots to add in that we could present that back to folks and say, does this seem right? Does this cover the waterfront of what we need to get done? Or does it allow us to prioritize the next few years of work? And here's what we can do, but there's some things we can't, we ONC. So where communities want to step in. And I need everybody to participate in that. That's why our wiki, by the way, is just completely open to the country. And we only have, I don't know how many comments we've had for our wiki roadmap, but all 318 million Americans can chime in if they want. healthit.gov. Then you just find the wiki. Y'all change seats, okay. I don't know what time it is, so you just have to, okay.
Good morning, everyone. Thank you, Luis, and thank you, Dr. DeSalvo. My name is Jitendra Barmech. I am the internist and CIO at St. Barnabas Health System in the Bronx in New York. We have a fair large number of population who has behavioral health and substance abuse like any other underserved communities in the country. Can you comment on the incentive payments for professionals who are serving these underserved population, why they were not included in the EMR meaningful use, or will they be in future will be included in the incentive payments as we move along with the integration of behavioral health and primary care with 2014 standards as NCQA is preparing?
So in designing the Meaningful Use Program, Congress defined the meaningful use providers and handed that to HHS to shape. So what they weren't, behavioral health was not a part of that. And so statutorily, we don't have that flexibility. On the other hand, we are learning from states. I'll use Minnesota again. But I was in Vermont, and they've done, Vermont, by the way, very progressive in behavioral health adoption. If you're looking for, it's Vermont, but if I had that many admissions in a year, they have 667,000 people in their state. But really progressive, very great and vocal behavioral health community who is really knocking at the door and wants to answer some questions about 42 CFR Part 2 about privacy of data. So at the state level, they're in Ohio, similarly, thinking through how they use monies from their ACOs or their SIM state grants or their SAMHSA or other dollars that they have to help support adoption and then integration of that data into the broader picture of health for the people that they're serving. You mentioned, and I think it's worth saying, we're sort of underscoring that this is a particularly top of the mind issue for a lot of the safety net providers in this country, particularly the federally qualified health centers, but also the VA, frankly, where they're really pretty advanced in integrating behavioral health and primary care. We had that sort of structure in New Orleans, and it was a huge challenge to have the appropriate privacy of the data, but also have it available. So there are other levers, as I mentioned, and we are working with CMS to think through what's the best way to manage that. I think there are some states, and maybe I'll just point you back to Minnesota, who's been pretty progressive of thinking that through and thinking how they redirect some of their state-level dollars to meet those needs and challenges. Maybe Kentucky comes to mind. If you wanted to reach out, we could try to give you a list of places. But ultimately, also, if those providers want to adopt a separate electronic health record, I want to make sure that it is standardized enough that it actually talks with the other systems. We've had 1,000 flowers blooming in this country around EHRs and health information exchanges and standards and policies, and it's been a great learning experience, and we've come pretty far, but the time has come that we standardize that because people don't have the money or time to very valuable resources to pay for or deal with interfaces so that systems can talk to each other. So we are committed to seeing that that sort of challenge goes away, that we have standardization, and that we're getting ahead of the certification for behavioral health and long-term post-acute care products. We've been working with our advisory groups, the FACAs, to lay out the principles and how that might look, and working with SAMHSA to think about what are the key core variables that we'd want to make sure include. So that's a certification opportunity we have, but it's also about our standards and interoperability framework to make sure that there's some core set of information that we don't allow for date of birth to be collected in 25 different ways, but we just pick one. That's it. Thank you guys so much. Keep up the great work. Thank you very much.